You're a very quiet audience, aren't you? Ladies and gentlemen, I'd like to thank the Innovative Medicines Initiative and the Critical Path Initiative for the opportunity to contribute to this meeting. We live in an ageing society, and I've been asked, as somebody who's obviously ageing, to give a patient viewpoint. I know I'm ageing because I start to use these, and I no longer write anything, I just type into an iPad. Our ageing society is something which is often portrayed as an issue and a problem. I actually think it's something that should be celebrated. As a society, we have risen to the challenges presented to us over the decades. We've addressed neonatal and maternal health. We've combated many communicable diseases through cleaner water, better nutrition, through antibiotics. We've prevented many diseases through vaccination. And how have we done this? We've done this through addressing those challenges head-on, through partnership, through innovation, through a determination to create a better world for our children and grandchildren. Today's challenges are different, but no less worthy of our efforts. Although we've been successful in preventing many diseases, and today we successfully treat and manage many forms of cancer and heart disease, a consequence is more chronic disease. Diseases such as diseases of the brain, which are arguably more difficult, more expensive, more complex. In Europe today, the costs of brain diseases annually is almost 800 billion euros, with mental health and dementias each costing more than 100 billion. And this is set to rise further. The general rising costs of healthcare, together with increasing barriers to the development and introduction of new medicines and devices, mean that the time taken to get products to patients is increasing. Patients simply don't understand or can't believe it takes so long from an idea to bring a new product to them. When you're diagnosed with a long-term condition, or a life-threatening one, being told that it will take 12 to 15 years to bring them the latest idea is small comfort. They want it now or tomorrow and are prepared to accept a level of risk which most of us might think is unthinkable, and they're being told that that risk is unacceptable by society. Oops. Historically, patients were focused on the need for a cure, above all else for the diseases that could be cured, and typically described the distress that they suffered when they wanted to get anything. Today's meeting is called Collaborating for Cures, and whilst I think none of us could disagree with this sentiment, I would suggest to you that when you're a patient suffering from a chronic condition, you may be focused on shorter-term goals, and cure may actually have little meaning for you. This also needs to be considered in how we develop new products and the value we ascribe to them. Historically, going back a number of decades, patients were not usually part of the solution. They were told what to do. They were peripheral to discussions, and particularly decisions on care, treatment options, and so on. And although they now play a key role in those sorts of discussions, their role in shaping new product development lags way behind. Over the next couple of minutes, I hope to show you that things must change in this regard, and patients should have a much greater role to play and address the questions posed on this slide. The single factor uniting everybody in this room is that at some stage we will all be patients. By the age of 65, most of us will have at least 3 disease processes underway, and for some of us, this is already happening. We all therefore have a vested interest in ensuring that patient need is adequately expressed and taken into account, both before, during, and after products have been developed and brought to market. Societal demographics, multiple disease comorbidity, polypharmacy, the advent of real-world data through electronic health records and other means, medicines with less borders, and global patient expectation of equality and fairness will and should drive changes in how patients are involved in product development. Politically, the voice of the patient will be heard more than ever before. But how and when should this voice be incorporated into new product development and refined to reflect new and changing needs? The answers are not simple, they're complex and difficult, but need to be part of all our thinking. Defining unmet need used to solely be unmet medical need. Doctors knew best on behalf of society. But actually, when you ask doctors what they think patients need and you ask patients what they need, there is about a 20% agreement. All too often, whilst fulfilling criteria of scientifically assessed efficacy and safety with objective validated endpoints amenable to change and that are reproducible, they are irrelevant to patients in their day-to-day lives. Improvements in an arm swing or a 6-minute walk may be quantifiable and reproducible, but usually mean little to patients who want to have enough breath to talk to their grandchildren, be able to do the shopping or visit friends and have good bladder and bowel control, something which is usually ignored. Much greater accumulation of real-world data will contribute to addressing this, but care must be taken to ensure that we don't just wait for this to be accumulated and add to the time taken to get valuable medicines to patients. Politics shape the creation and maintenance of the innovation environment critical to most of us, and politicians are therefore important. In this regard, patients are their electorate and more likely to be listened to than business or academia if their voices are united. Unity in creating a common agenda will create a powerful voice for change. But are patient groups and patient advocacy teams ready for this? Perception of the needs and value of patient and patient advocacy groups vary tremendously, partly because of prejudice, because they don't think people are organised enough, partly through experience. Often, indeed, patient groups are very small, driven by very specific agendas, and do not really understand drug development sufficiently today to input sufficiently. This does not mean, however, that moving forward, new partnerships with clear rules of engagement, common goals within mixed agendas, the development of new competencies, new alliances, new approaches should not be explored and developed. Power comes from greater patient numbers acting together with a common purpose, with mutual respect for their independence and industry being more united in their approach, as well as the same being true of patient groups. We all need to think initially, look at the big picture. In that pre-competitive space, develop expertise at therapy area level and disease level before an individual drug or treatment is assessed, to build expertise and input before focusing on individual trials and development plans. Specific measures such as patient-reported outcomes have been developed and are being used to reflect the real world of the patient. But these are not today wholly satisfactory, with too much diversity. Less regulatory and payer agreement than is ideal, but this does not mean that we shouldn't build on early attempts and success, far from it. All stakeholders, especially academia and patients, should lead new approaches, develop methodologies and drive unmet patient need into the more scientific, the quantifiable, but also relevant for the patients in the real world. Industry, perhaps using the PPP model as part of consortium, can help facilitate this and create new measures that can gain the endorsement of regulators and payers worldwide. This will require a significant paradigm shift, not least from patients and their representatives, taking a longer-term view which may be alien to those with an immediate diagnosis and need. Although there are clearly differences in geographies around the world, for much of the globe there are more similarities than differences. The environment within which patients may suffer may differ, but fundamentally a patient with a given disease is the same wherever they live. Global development has become the only economically sustainable model for pharma, with some tailoring for geographies. Partnering, particularly between the EU and the US, where patient groups are currently much stronger, are more organised, have more influence, is the way forward, and we need to grow this over time. Greater collaboration between the EU and the US, between regulators and payers, between science and academia, and particularly between patient groups, can hopefully help deliver the patient voice in a way that can be utilised by all those who work in bringing important new products to patients, enabling them to recognise and meet unmet patient need. Together, as patients now or in the future, we all need this to work. Thank you very much.